Vă mulțumesc în primul rând că ați acceptat invitația noastră și sper că în urma discuției pe care o vom avea cu doi mari specialiști în chirurgia creierului, veți afla informații destul de importante. Alături de mine l-am pe domnul profesor dr. Talat Cârâș, dumnealui ambii de fapt, și domnul profesor Özenç Minareci, ambii sunt de la spitalul Florence Nightingale și au venit în România, am aflat acum câteva secunde că sunt pentru prima dată aici, și a venit în România ca să ne împărtășească un pic din experiența dumnealor și să ne spună cât de greu sau cât de ușor este să operezi pe creier, mai ales că vorbim despre niște tumori. Înainte de a începe dezbaterea propriu-zisă și de a invita pe domnii profesor să ne vorbească despre o nouă tehnologie în tratarea tumorilor la nivelul creierului, aș dori să vă fac o scurtă prezentare, să vă spun cine sunt acești doi profesori stimabili care au acceptat invitația de a veni în România. Aș dori să încep cu domnul profesor Talat Cârâș. Dumnealui a profesat nu numai în Turcia, ci și în spitale de prestigiu din Marea Britanie, Statele Unite. O să-l întreb dacă are în plan în viitor să vină și în România și să profeseze aici, în spitalele din România.
I don't know. Is it possible? If yes, why not? I don't know if foreign doctors can or can't operate in Romania.
Credeți că doctorii de la noi nu ar putea opera?
No, I don't know actually the Romanian doctors. I am sure they operate perfect.
Domnul profesor Talat Cârâș este șeful secției de neurochirurgie al centrului Gamma Knife din cadrul spitalului Florence Nightingale și președintele secției de neurooncologie din cadrul Societății Turce de Neurochirurgie. Atât domnul profesor Cârâș, cât și domnul profesor Minareci lucrează împreună de mai bine de 20 de ani. Ambii și-au format o echipă multidisciplinară de medici și operează împreună în spitalul Florence Nightingale. În cei 20 de ani de experiență, cei doi au format, așa cum am spus, o echipă de profesioniști care au capacitatea de a le oferi pacienților cele mai bune alternative de tratament într-o manieră deschisă, astfel încât pacienții să ia decizia finală în cunoștință de cauză, știind atât riscurile cât și beneficiile unui tratament care ar putea să beneficieze. Domnul profesor Özenç Minareci este unul dintre pionierii din Turcia care a început să lucreze în neuroradiologia intervențională. Am I right?
Yes, that's right.
A înființat primul departament de neuroradiologie din Turcia în 1989, iar de-a lungul carierei sale a efectuat mii de tratamente endovasculare și a pregătit un număr considerabil de rezidenți, astfel fiind medici practicanți de succes atât în Turcia cât și în țările vecine. Aș avea de asemenea o întrebare pentru profesorul Minareci. Ați pregătit mii de medici. Știți dacă cumva printre medicii pe care i-ați pregătit există și medici români care lucrează acum în România?
Unfortunately, not yet.
Not yet.
Hopefully.
De asemenea, aș dori să vă facem o scurtă prezentare a spitalului unde doctorii lucrează. Nu este un simplu spital, au o au foarte multe specializări, iar serviciile lor nu se adresează doar pacienților din Turcia, ci și inclusiv românilor. Din câte am aflat că sute de români vin anual ca să se trateze în clinica aceasta, ceea ce înseamnă că prețurile, zic eu, sunt destul de accesibile. Aș dori să prezentăm un scurt filmuleț despre spital.
There's an institution in Turkey to take care of your health. An institution always up to date and pioneer of innovations. The group was named after Florence Nightingale, who defined the rules for sanitation and hence started the modern nursing. The hospitals of the group are located in Istanbul and a facility in London. Group Florence Nightingale has a total capacity of 700 patient beds, 122 intensive care unit beds, 75 emergency and observation beds, and 36 operating rooms, and employs 3,000 personnel, including 515 permanent staff doctors, 542 nurses, and 309 healthcare technicians. Shishli Florence Nightingale Hospital, the first hospital of the group, started providing medical services in 1989 with a capacity of 50 beds. This hospital has increased its bed capacity to 300 and currently performs more than 2,000 open heart surgeries annually, as well as bone marrow, heart and liver transplantations. Shishli Florence Nightingale Hospital, with its 12 operating rooms and 47 intensive care unit beds, maintains its feature of being a reference hospital for complex cases. Gayrettepe Florence Nightingale Hospital, the third hospital of the group, was opened as a 102-bed hospital in 1997. Comprehensive Cancer Center of the hospital, with its qualified staff and modern equipment, works in collaboration with the globally renowned New York Memorial Sloan Kettering, Houston MD Anderson, and Detroit Karmanos Cancer Institution. Regarding diagnosis and treatments, individualized cancer treatments are provided and family-centered care complements the services. Individual cases are discussed by the board of the specialists so that active treatment strategies are developed. Gayrettepe Florence Nightingale Immunology Hemato-Oncology Genetic Diagnosis and Research Center offers services with its qualified specialists and international connections for the diagnosis and treatment of genetic diseases and immunogenetic and cancer immunology. In the Radiotherapy Center, IMRT system, which provides a special protection to the organs at risk, is used to deliver radiotherapy. Thanks to the multi-layer computerized tomography device, the cardiac vessels can be viewed in only 8 seconds. This device also allows the three-dimensional view of the respiratory and urinary systems. With the 16 multi-detector PET-CT device, cancers can be diagnosed at very early stages. Gayrettepe Florence Nightingale has a constant quality improvement policy in all other branches it provides services, gynecology and obstetrics, and aims to move its place among the best special health institutions further. Göktürk Florence Nightingale Medical Center and Kadıköy Florence Nightingale Hospital on the Asian side of Istanbul are open to provide service in 2007. Kadıköy Florence Nightingale Hospital offers services for diagnosis and treatment in all branches as outpatient or inpatient, including emergency services. Due to being the only hospital on the Baghdad Avenue and its central location, the hospital has a feature of being the first choice for emergency cases around the area. The hospital owns fully equipped operation rooms in which all types of surgery, including heart surgery and liver transplantation, can be performed, intensive care units, and an advanced radiology center. Istanbul Florence Nightingale Hospital is located over against the Abide-i Hurriyet Park. Istanbul Florence Nightingale Hospital is the first green hospital of our country. The hospital provides service with 219 patient beds, 51 intensive care unit beds, 2 delivery rooms, and 11 operating rooms. All operating rooms have laminar airflow technology, and one of them is a hybrid theater. The operating theaters can be connected to the conference room with a 300 seating capacity and to international points with the latest technology. By using these technologies, interactive medical education and scientific activities can be organized. The physiotherapy department provides service in world standards using conventional therapies as well as contemporary methods, such as hydrotherapy, airwalk, and MIHA. The first EOS device in our country provides the three-dimension X-ray imaging of the skeleton by using ultra-low-dose radiation. Istanbul Florence Nightingale Hospital is cooperating with Turkish Airlines for patients coming for diagnosis and treatment from the countries in the region. Group Florence Nightingale distinguishes with its expertness at most sensitive branches like cancer, transplantation, thoracic and brain surgery, and especially in the diagnosis and treatment of cardiac diseases. Also, Group Florence Nightingale pioneered practicing the heart surgeries without opening the rib cage and prostate surgeries without opening the abdomen by dint of Da Vinci's surgical system. Florence Nightingale, which succeeded numerous liver, kidney, and pancreas transplantations due to its worldwide triumphant staff, provides for paralyzed patients. In Florence Nightingale hospitals, it's possible to identify many inherited diseases before and after pregnancy and at the embryo phase. The group takes justified pride in owning accreditation certificates of German TÜV, one of the biggest establishments of the world, the American Joint Commission International, as well as ISO 9001. It contributes to human health with yearly 2,000 open heart surgeries, 1,200 orthopedic surgeries, more than 10,000 surgical operations, treatment for 1,000 new oncologic patients, and 200,000 outpatients, and all of this with a modern perspective. Group Florence Nightingale also redounds new, qualified, and competent medical staff to our country and region. In the Turkish Republic Istanbul Science University, which was established as the first medical university in 2006 and is managerial connected to Turkish Cardiology Foundation, are being raised qualified doctors, nurses, and allied health personnel. Group Florence Nightingale, always breaking new grounds in its field, keeps on expanding and offering the best possible service, accompanied by its precious doctors and personnel, and the responsibility of being reformist and being an initiator all the time. Always new, always renewed, Group Florence Nightingale, at your health's disposal.
În continuare, aș dori să-l invit pe domnul profesor Talat Cârâș, care să ne vorbească un pic despre Gamma X Perfection, o nouă tehnologie în tratarea tumorilor de la nivelul creierului. Din câte știu, această tehnologie, Gamma Knife, este în prezent folosită la nivel global în 275 de centre. Până în prezent, peste 670.000 de pacienți au beneficiat de un astfel de tratament. Aș dori ca domnul profesor să ne vorbească un pic despre această tehnologie și să ne explice care sunt beneficiile și dezavantajele unei astfel de proceduri.
Gamma knife is not a new technology, but the perfection, the new model is actually a kind of new technology because after 30 years of establishment of Gamma knife, the company Elekta changed the hardware completely and also the software. So we have this new perfection. With perfection, we can treat not only tumors, but also some vascular malformations and some functional diseases like trigeminal neuralgia, like the face pain. It's very simple. It's one-day treatment. We don't use general anesthesia. The patient comes in the morning. We treat, and most patients from abroad can fly back on the same night or the next day.
Scuzați-mă, ați spus că pot zbura sau nu am înțeles, they can fly back, este ok după o astfel de intervenție să te urci în avion și să nu e presiunea mult prea mare la nivelul creierului?
No, exactly. That's the beauty of this treatment. A Turkish patient can go to restaurant, have a wine after treatment, and the patient from abroad can fly. We have many patients. When they want to see Istanbul, it's not a problem. They can stay. But if they want to go, they can go. It's a minimal invasive technique. And although I am trained as a skull-based surgeon, many things change in medicine. Nowadays, the patients want not big surgeries. They want really minimal invasive. They want to go back as early as they can to their work, to their normal life. So this gamma knife is an option in many cases.
Iar aș dori să ne spuneți și câteva riscuri, dacă există.
Of the gamma knife, yeah, the gamma knife is actually a high dose radiation therapy, but the importance is it is focused. It is focused on one area, so you can measure very accurately the neighboring structures of the brain, how much dose they receive. So it is practically the gamma knife treatment has very, very, very low complication rate because you can measure almost everything before the treatment, and you change your gamma plan. You can say, for example, if there is a tumor close to the optic nerves, to the eyes, we know that the optic nerve can tolerate 7 gray. So we reduce our dose, or we play with the treatment plan. So really, it is practically in medicine there is no zero risk, but it is very close to zero.
Încă o întrebare. Această tehnologie gamma knife înlocuiește operația clasică sau sunt îmbinate?
Actually, both. In some cases, in some tumors and vascular cases, it's replaced. For example, there is a tumor called vestibular schwannoma. It's from the nerve, a tumor from the nerve that we hear. We operated many of these cases, but nowadays gamma knife can control the growth of this tumor about 95-98%. It's a very difficult operation. We practically don't operate anymore. If the tumor is not big than 3 centimeters, we have a limit. If it is bigger than 3 centimeters, then we operate. And the second part of your question, in some cases, we operate, for example, we remove 90% of the tumor, and for the rest, we do gamma knife treatment. Or we collaborate together with Professor Minareci in vascular malformations. He embolize a part of the vascular malformation, and the rest we operate or we do gamma knife. So it is not only for tumors, it's also for vascular cases.
Acesta probabil este și motivul pentru care aveți o echipă de medici multidisciplinară și nu faceți doar dumneavoastră astfel de operații.
No, we work 20 years. I don't remember, a long time.
More than 20 years.
More than 20 years, and it's, he can also tell. But we start with discussion. It's very important, not only to do together something, but we build a strategy for every patient individually. what should we do in that patient? Even if he don't do anything for this patient, we discuss together the films. He pointed out something, and if it is vascular case, we discuss for some aneurysm cases. It's suitable for interventional neuroradiology, some for surgery, and in most centers, people fight for the cases. We don't do this. We collaborate, actually.
Actually, one-man show era is all over.
Yeah, exactly.
From now on, there's no place for one-man show. It's the time for working together, collaborating, discussing, and making the brief decision about the patient and the most safe, most benefits. So we try our best to keep in that road.
Domnule profesor Minareci, aș dori dacă ați putea să ne vorbiți un pic și despre intervenția mini-invazivă, neurologie intervențională.
Let's say not neurology, but neuroscience, let's say. Because there are some disorders related to neurosurgery, and there are some disorders related to neurology that we all both deal with those kinds of disorders in discipline of neuroradiology. And as a neuroradiology all over, as you know, neuroradiology is a branch especially which is responsible of diagnosing the disorders with the imaging technologies. And we can divide neuroradiology in two different parts. There's a diagnostic neuroradiology, and the other part is interventional neuroradiology. And interventional neuroradiology, yes, we do mostly deal with the vascular problems, whether they are aneurysms, intracranial vascular malformations, fistulas, or some other kinds of stenosis, intracranial or extracranial stenosis. So in some parts we collaborate with the neurologist colleagues, and for the most part, actually, we collaborate for Krish and his team. And what we do is to travel along the arteries, getting into the artery for most of the time from the groin, and travel all along the way to the uppers, into the brain, into the diseased area of the vessel, and to repair the vessel from inside.
Sună, cum ați spus, science neurology. Este un lucru foarte interesant. Sunt doi oameni care se ocupă cu vasele de sânge care odată ce, dacă nu sunt foarte bine manevrate, să spun așa, riscul de a deceda pe masă este destul de ridicat și domnul profesor Cârâc care operează pe creier, dar un lucru deosebit este că domnul profesor este un navigator. Și eu am aflat câteva cuvinte despre câteva povești ale dumnealui, dar aș dori, dacă poate, să ne împărtășească cum e posibil ca după ce operați pe creier să mergeți și să vă plimbați prin Antarctica, să faceți poze cu pinguinii. Este o experiență deosebită.
Yeah. Maybe this is the way to relax. It's actually not a relaxing journey. I am a sailor and I like adventures. So recently I did two journeys, one to Greenland and one to Antarctica. Maybe you asked this. And he did some to Mexico and some to Amazon region also. And I think I am in a certain age now. I can plan my time, and the life is short, so we have to do what we want to do actually. Operating is good, but sailing to Antarctica is better, I think. I recommend you.
Actually, we're collaborating in our lifestyles too. He's a seaman and I'm a landman.
Yeah.
And I travel the lands and some wild areas, and I've been good friends with some wild animals too.
Ați văzut un leu de aproape?
Sorry?
Un leu, l-ați văzut de aproape? Ați văzut vreun leu, vreun...
Yeah.
Expediții împreună ați făcut?
Yeah.
Cum ar fi, unde ați mers împreună? În ce colț din lume?
South Africa. South Africa, yeah.
And I saw a whale very close, just like you and me. Actually, many whales. It was an experience.
You know, the title of this meeting is the challenge, the brain always challenge. So we're very used to challenge. So it's his kind of challenging, the sea life, and it's my kind of challenging wildlife. So we challenge as always.
Aceasta a fost prezentarea noastră. A fost scurtă, dar am spus să fim scurți și la obiect. Dacă aveți întrebări, domnii profesori vă stau la dispoziție și sigur vă vor oferi cele mai...
My name is Andrei Cârchelan and I'm from a business daily called Özenç. So, how many Romanian patients do you get? Do you get many Romanian patients at your clinics on a yearly basis?
Actually, it just started for neurosurgery when I talk for neurosurgery. I know that in our hospital, other groups operated more Romanian patients. We receive patients from all parts of the world, actually. But I think we treated 2 or 3 Romanian patients, not more. But they are always welcome.
I see. And do you see any differences in afflictions by region? Do certain patients from certain countries suffer from certain afflictions?
Maybe patients from Arabic countries, mostly from Iraq, they came with very big tumors because the diagnostic facilities are not good in that area. So the patients are diagnosed very lately, and I saw such a tumors maybe 30 years ago in Turkey. Nowadays we have in every piece of country an MRI or a CT scan. So in Turkey patients are diagnosed very early. But from mostly from east part of Turkey, in the other countries, such as Iraq or Libya, for example, they came very late. So it is a challenge then. Very big tumors, the patients come sometimes in a not good health situation, but we try to help them.
I see. Was your activity disturbed in the latest social problems? Was your hospital in danger? Did you have any, refugees from the protests and so on?
Actually, personally speaking, I was one of them. I was always in Gezi, and I'm a member of medical chamber, and I tried to help the people. The last boy who died because a police shot from a gas bomb is consulted by me. They come to me, and it's not very close to that region, so we treated some of them. But mostly, I treated people on streets.
I see. So gamma knife can also deal with trauma?
No.
No? So the little boy, the boy, not the... Was this a trauma case or a chemical affliction?
No, trauma. It's shot from very close distance from the head, unfortunately.
I see.
I don't know, am I allowed to talk politics here?
On a casual level, not as an official point of view.
It's not a problem. We can talk everything.
How difficult are the logistics for such a center? For example, if there is a blackout, if the power goes out, how many minutes or hours do you have until you are left without power completely? Say that such a blackout catches you during an operation. How do you handle emergencies? Is there a generator?
I think there's sure a couple of generators actually. I think it's a standard. So 10 seconds or 15 seconds is max.
Is
so,
that enough?
Yeah, definitely.
Just to close the skull and...
No, we have the generator start.
Actually, for those critical parts or for the critical rooms, there's an uninterrupted power supply facility. And we do not feel whether the electricity is off or not on. We don't feel it. It goes uninterrupted.
I see. And your patients, are they mostly Turkish or mostly foreign?
Maybe 70% are Turkish, 30% from abroad, I can say.
And the others, how? What's the region they come from? The majority, where do they come from? Are they Russians, for example?
We have Russian patients from, as I mentioned, from Iraq, from Georgia, even from Europe. We have patients from Libya, Tunis, from Turkish countries like Uzbekistan or Kazakhstan.
Saudi, United Arab Emirates,
But
and some patients from Albania, Macedonia.
when I last checked, I treated patients from almost 50 countries because some tourists come to Istanbul and they have a problem, and altogether from 50 something like different countries, I operated patients.
I see. And are you able to talk about the average cost of an intervention at your center? How much money would I need if I sought medical attention?
I don't know this.
That's
It
the
depends, it
specialist
depends on your condition.
prerogative. And on an international level, there's Istanbul, and what else? What is your competition? What cities? Say I'm a patient with infinite means, and I have a choice. Istanbul is one. What are the other choices?
In Turkey, you mean?
No,
Or-
internationally. In London, in New York, who do you compete with in terms of your area of practice?
I mean, there are good centers in some parts of the world. For example, I worked in States, and I know some hospitals in the States you don't want to go. Very bad hospitals, but there are perfect hospitals. And now there is internet. You have to find. And all the patients check in internet when they come. They know everything about me. Everything, my journeys, my daughter's schools, everything. They check every aspect of our lives and our hospitals. Now it is easy for the patients. Sometimes we receive emails. Recently, there was an email from Krakow, Poland. A patient wants to come for gamma knife treatment. And I replied, and I said, okay, and these are the conditions, this and that. And he said, okay, can I come on Saturday? And I said, yeah, why not? And I think someone is joking me. So I went on Saturday, and I saw a guy with in front with the luggage in front of my office, and he said, can you treat today? Okay, we can treat if you want, because I want to go this night, he says. And we treat. It was a trigeminal neuralgia. This is the modern times now.
I see. Okay, Mr. Minareci, what's next? So, gamma knife right now. What's the next step in the evolution of the practice. What do you feel the progress should undertake?
In neuroradiology, interventional neuroradiology,
Yes.
we still need some improvement in our technology, in our knowledge, so that probably in the next level we will use some other devices endovascularly to treat the vascular problems. And probably they are going to be biologically active materials. Nowadays we use mostly with the metallic devices, platinum or tungsten or nitinol, something like that. But probably in the future, probably in the really near future, we're going to use some bioactive materials which are going to dissolve after finishing the mission. So, and probably we will get some medicines which can control the biogenetic activity of the disordered part to treat it itself. Probably we will not do our job anymore in some decades. It's not a near future, but it will occur. We'll see if we have time.
And in terms of transplant, right now transplants, are they not done because they're not possible or because they're old and obsolete?
Which transplant?
Brain transplants are not possible, but transplantation in medicine, do you see it as the future or the past? A patient ideally requires a transplant or the modification of their current structure and healing.
Probably transplantation is just at the maximum level of its era, and maybe in the future we're gonna use some three-dimensionally printed tissues, and it has just started. For example,
Prosthetics.
Prosthetics. For example, I know that they had done such an operation in London for face transplantation. Rather than bringing a face from somebody else, they have created a three-dimensional printer. They have created such a, let's say, prosthesis, and they have transplanted it. Probably we're going to use that kind of products in the future, or probably we are going to, stem cells technology will improve. Who knows?
I see. And how much would you say we know about the brain? Imagine the brain as the planet. How much of it do we know right now for sure?
It's really a tough question. To make an estimation, we have to have an idea about the whole brain.
Yeah.
If this is 100%, I know this one, so I can say I know 20% or 30%. But actually, as the space, we don't know the end. And also, brain has different aspects: physiological aspects and behavioral aspects and mental aspects. So if the individual gets more intellectual, the philosophy, the behavioral patterns are all improved, and probably we will never get to the last point. But from the morphological point of view, we know most of the brain, and probably millimeter by millimeter we know which part does which job and how it's transmitted, how it works. We can image most of it to our knowledge, but we'll see.
I see. And in your area of practice, how much are we talking about prophylaxis? How much about treatment? And how much about containment?
My patients who are applying for interventional neuroradiology practice mostly have some problems with atherosclerosis. So for prophylaxis, we recommend the people to protect them against atherosclerotic risk factors, especially smoking. And you can't do anything for your genetics, but you can control the other aspects. And on the other hand, there's nothing much to do for prophylaxis in brain disorders.
Yeah. And treatment? Is treatment the majority of cases, are they treatable cases or they are contained?
Most of them are treatable. Most of them are for vascular problems, which I deal mostly with. most of them are treatable. Untractable cases are very rare.
I see.
Actually, it depends on the condition of the patient. If the health condition of the patient is in a poor condition, so you can take the risk of making an operation on that patient, but whereas you can do the operation on a different patient for the same kind of lesion.
I see. And a question for both of you. Do you offer consultations online? Does new technology help you collaborate with doctors abroad, overseas, and so on? Have patients contact you over Skype, say, or over the phone and say, I have this pain here and there, and you would advise them? Have you ever done this?
Not yet. Not with Skype, but this is a good question because for me the most important problem with the patients from abroad is when you choose a doctor, it is not a mechanic thing. We deal with humans. We don't treat robots. The patients should trust you. We should come face to face. It's like love. Really, it's like that. And we just talk with Dr. Defne. We have a teleconference system. We should consult patients not from emails only or from papers. We should come face to face. And then they can really choose from a doctor from New York or London or from Istanbul. They should trust you. It is not really only technology, only experience. This should be, but also some human relation between doctor and patient is important. When we operate, there are two brains facing each other, like a planet, two planets, my brain and the patient's brain. So it's important to understand each other.
And on the other hand, even though if we consultate about a patient abroad by mail or by some other way, we need to know all the details about the patient. My major complaint is that I receive some consultation questions all over. And most of them, what they do is just copying the result of the MR scan and pasting it to my email and then sending it to me and says, what you say.
But what other details do you need? Smoker, non-smoker?
Smoker, non-smoker, how old is the patient, what is the clinical findings, what is the physical examination finding, what are the lab results, what is the history of the patient, what is his lifestyle, what is expecting from life, and what is his professionality. In some cases, yes, we do treat the cases, but there is a little bit risk of getting a little hemiparetic or paraparetic or something. There might occur some neurologic deficit. I need to know whether the patient is just relying on that facility that might get into trouble or not. For example, if you're a pilot flying with an aircraft, I cannot take any risks. But if you're just a guy sitting on the table all the day and counting something like that for the all day, I can take some risks of making a little bit right leg hemiparetic or not. You understand what I mean?
Yes, I do.
To make a decision, we need to know everything about the patient and his family and so on and so forth.
Okay,
And also, what we want to decide about the pictures is, now today's electronic technology is so improved that I prefer to get the images via Dropbox. Yeah. Not only single shots, but if they load all the images to the Dropbox, I can review it from my computer from anywhere. So I can have a better idea.
I see. Thank you very much. That's all.
I wanted only to explain something about the telemedicine system. We have already the system, and if the other part also has the same technology, then we can connect, and the doctors or patient and doctor can discuss about the problem together. You have already the system.
Mai sunt și acolo în spate, la...
Bună ziua, sunt Mădălina Drăgoi de la Ce se întâmplă, doctore. Tratați și copii? Operați și copii?
Yes. I operate when they have tumors or vascular problems, mostly. If they have congenital problems, then in my team I have different neurosurgeons with different interests. So we have also pediatric neurosurgeons in our team. So they operate. But if there is a tumor, so I want to be in the OR and to operate.
And my youngest patient I've ever treated was 4 hours old lady. Yeah, she was only 4 hours old, and she had a diagnosed galenic venous malformation in the brain, which is a great shunting between an artery and a vein, so that in the prenatal period, during the pregnancy of the mother, she was diagnosed to have a cardiac failure. So in order to save her, we had the operation just after birth. She was the youngest one.
Și acum este bine această fetiță?
Sorry? She's okay. She's okay. When she visits my office, she disturbs everything all around.
Ați putea să ne spuneți să ne dați exemple de câteva alimente care ajută creierul să fie sănătos?
I recommend to my patients, eat everything what you want. Drink, eat, don't smoke. Life is short, but this is not the real answer maybe. I should advise broccoli or this stuff, but I don't like broccoli. I like beef, fish, and, and we will die someday. You can eat everything. Everything is good for brain.
To me, that knowledge is also changing in time. If you remember those old days, egg was restricted. We weren't permitted to have that much egg because of high level of cholesterol. Now, they do advise us to eat egg or some other stuff like that. So the understandings are changing, the concepts are changing, but I agree with Talat that we have to enjoy life.
Don't eat too much.
Yeah, moderate.
O ultimă întrebare. Cum afectează tutunul, fumatul, cum afectează creierul? Dacă există o legătură directă între fumat și afecțiuni.
Actually, smoking affects every part of our body, every single part. So don't smoke. Even the brain, especially the vessels, the brain vessels. And if you have an aneurysm, a balloon in your brain, the smokers tend to bleed more. So smoking is not good. You can drink wine, good wine, but don't smoke.
Microfonul este pe masă.
Thank you. How do you deal with the language barrier when dealing with patients, foreign patients? Do you have translators? Do you gesture? What do you do?
Yes, not gesturing. And we have translators, many translators and multilingual.
And do
We
you
can
have,
cooperate with the patients, there's no problem.
I see. And in Istanbul, do you have foreign doctors working?
Actually, it was not allowed for the foreigners to practice medicine in Turkey, but nowadays, as I know, they are changing the rules that can allow some foreign doctors to practice in Turkey.
So do Turkish doctors mostly go to London, or do British doctors come to Istanbul? What's
For what?
the interest? For exchange of experience, for
For
I don't know,
both, for
activity?
both. For
It's a
both.
constant shifting of
Sure,
medical staff.
sure.
I see. Thank you.
The system in England is not very good, the health system. In the past, it was actually one of the best systems. But after Ms. Thatcher, it's not good. If you live in England and you suffer from low back pain, it took you maybe a year to get an MRI from your back. Really, the health system is not very good. Or you have to go to your GP, general practitioner, and the GP sent you a doctor. You can't choose your doctor. It's not possible. I worked in England, and I think they have good centers, very good centers, but the general system is, for me, not very good.
I see. And from what you've heard from other doctors or in your clinics, is there a change in the behavior of American patients? There are changes in their healthcare system right now. And I was wondering if you have seen fewer American patients or more American patients coming from across the Atlantic and going to London or coming to Istanbul? Or is
We don't have enough experience because it's a very recent change.
Yeah, they stay there.
In the health politics in the U.S., it's very recent, so we don't have enough experience. We're gonna see what
I
will
see.
happen. Yeah.
But your hopes are they'll come here.
Sorry?
But your hopes are that they'll come to Istanbul and
Probably, we'll see.
The problem in health system in all of the world, now mostly the insurance companies control the medicine because they pay and they don't want to pay much money. So they somehow influence, at least they try to influence the treatment systems. And for the future, I think it will be not better, it will worse. Because when you measure medicine with economical parameters, it's not good.
I see.
From economical point of view, it's the reality that most of the big hospitals are owned by big insurance companies. They give this service, they pay for themselves, and they get the money from the patient. And so they pick the money from one pocket and put it on the other hand. So they don't want to diverge this amount, this budget to the other countries. On the other hand, the medicine is getting more expensive and expensive because it depends on the technology. Technology means some money, spending some money, and they use the same MR scans, they use the same angio suites, and we've got the same MRs and the same angio suites. So the cost is almost the same. What's different is that probably in our countries, we are a little bit cheaper doctors than in the States. And in the meantime, probably those colleagues in the States will practice for a smaller amount of money to compete with the other parts. We'll see what's going to happen.
I see. How important is patient culture the culture of the patient when you're dealing with them? You know best, are they opposing you, are they debating you in terms of treatment, or do they just listen and submit? How? And with addition, how many lawsuits do you get?
Actually, it depends on the social and intellectual level of the patient. If the social and intellectual level of the patient is well enough, we have a very good cooperation. I love the patients who are asking about their disorders, the treatment options, about his or her future. I love this kind of patient to discuss about the disorder, to discuss about what I'm doing, and I want her or him to respect what I'm doing for him. On the other hand, if the patient's intellectual or social status is a little bit not that high, not the bottom line, but not that high, they don't respect what you're doing. They come against you and say, the first cut and you're the second, you can do whatever you want. I don't want that position. I want to discuss about all the disorders. I want to inform him or her to get her idea and make a common decision. In some cases, I feel a bit disappointed and depressed, but of course I try my best, but my attitude and behavior is a little bit gets depressed.
I just also want to answer this question. We are doctors. We have to help the people, but it's not a matter their culture level. We have to try to cooperate with them. Even if their culture level is at the bottom, we should be kind, we should be polite. He's right. The patient doesn't understand very good the complications rate. But if the patient see a good human being, a good doctor, you understand what I mean? Not a very skilled doctor, but a human doctor. Then they trust you. And I always tell my students, my assistants, you must be polite to your patients, whatever they do, because our job is to help the people. We cannot shout at patients. It's for me the biggest mistake. if my assistant shout at patients, I shout him. Yeah, that's a relation.
Vă mulțumesc foarte mult. Din păcate suntem un pic în întârziere, dar vă invităm la o pauză de cafea unde cu siguranță medicii vă pot răspunde în continuare la întrebări. Vă mulțumesc foarte mult și sper că a fost o discuție interesantă.
Thank you.
Thank you.
Thank you.